Assalamualaikum and good morning everybody. Today's topic is about pharmacology of peptic ulcer disease. Right? Topic that I will cover in this lecture, peptic ulcer disease. I will touch on the definition, causes, sign and symptom, how to recognize this disease, physiology, and the complications of peptic ulcer disease. I will also cover H2 receptor antagonists, proton pump inhibitors, Antacids, prostaglandins, mucosa protective agents, and antibiotics for Helicobacter pylori infections. Let's start with the definitions. Peptic ulcer disease means the ulcerations or erosions of the lining of the upper portion of gastrointestinal tract. Okay. The disease include gastroesophageal reflux disease, gastric and duodenal peptic ulcers, and stress-related mucosal injury. Normally, the ulceration occurs at the mucosa of the stomach or duodenum. At the lower part of the esophagus, this is usually involved only inflammation. There were several causes of PUD, right? Number one is when there were increased secretion of hydrochloric acid. Example is Zollinger-Ellison syndrome, right? The second one is due to the defects of mucosal layer defense, right? The third one is due to adverse effect of Antacids. As you know, Antacids will prevent prostaglandin formations, which is an essential substance for the maintenance of mucosal layer defense. Alcohol, tobacco, and caffeine are the substances that will stimulate the production of gastrin. Therefore, it will increase the production of hydrochloric acids. Stress is also significant causes of PUD, right? It can be mentally stress or stress due to operations or major disease, right? One of the most important causes of PUD is due to Helicobacter pylori infections. The majority of the causes of duodenal and gastric ulcer are due to these infections, right? If we treat the ulcer without eradicating these infections, we will get higher recurrence rates. So with these 5 causes, we can also have 5 principal treatment of PUD. Number 1 is to reduce the hydrochloric productions. Number 2 is to improve the mucosa defense. Number 3, we need to talk with the patient, ask them to stop taking Antacids and to stop taking all the other risk factors, right? And try to reduce the stress or take prophylaxis treatment before undergo major surgery. Okay, and kill the bacteria with antibiotics and follow together with the acid lowering agents. Right. There was an estimated lifetime risk of 10 to 20% for the development of peptic ulcer disease. Right? So it is a widespread disease. Okay, you will frequently see this patient in your clinics. All right. Commonly, PUD presented with epigastric pains, and it is burning in nature. Burning. Sometimes they will also complain of bloating, belching, and vomiting. In gastric ulcer, the patient will normally have increased epigastric pain while eating. Therefore, the patient we reduce the intakes and we lose weight. Contrarily, for the patient with duodenal ulcer, the epigastric pain will reduce while eating. So this will make the patient gain weight. Right? There were several ways to diagnose PUD, right, including breath check and antigen detection. But for the confirmative diagnosis, a gastroendoscopic procedure must be done. Right? During the endoscopy, the ulcer biopsy will be taken and sent for pathology, culture, and sensitivity tests. There is two important physiological knowledge that you must know before you know how to treat PUD. Number one is gastric mucosa protections, and number two is system that were controlling acid secretions. We revise a little bit of physiology. Gastric mucosa protection was provided by surface epithelial cells which secrete mucosa, bicarbonates and prostaglandins. Alright. All these three items, we maintain the integrity of the mucosa. Okay. Besides that, mucosa of the stomach is very adaptive to the environment. The progenitor cells of the mucosa, we always try to renew the damaged cell. The parietal cells is the cell that produce hydrochloric acids. It is located at the epithelial cells of the fundus and cardia of the stomach. Basically, the production of acid hydrochlorides of the parietal side is activated by four substances through their receptors. Okay. Number one is gastric. Number one is the gastrin. Gastric, we stimulate CCK gastrin, we stimulate CCK receptors at the parietal cells and also at the ECL cells. ECL cells mean enterochromaffin light cells, right? So ECL cells, then we release histamines. Okay, the peptides present in the foods, we stimulate the production of the gastrins. All right. It also stimulated by caffeine, alcohol, and smoking. All right. The histamine released by ECL, we add on the histamine H2 receptors at the parietal cells. All right. Then the activations of muscarinic receptors we also stimulate the production of parietal cells. All these three activations of receptors, gastrin, CCK, histamine, and muscarinic, we increase the activity of protein kinase. All right. This activation of protein kinase, we increase the secretion of hydrochloric acids. The presence of prostaglandins E2 at the prostaglandin E2 receptors, we inhibit the protein kinase activation. All right. Thus, this we reduce the production of hydrochloric acids. All right. Treatments of PUD we involve reduction of stimulations by gastrins, reduce the intake of caffeine, alcohol, or smoking. We reduce the production of gastrin. All right. Or by giving the antagonist of H2, antihistamine, for example, cimetidines. All right. Or by giving antimuscarinic, for example, pyrazipine. But nowadays, we rarely use this agent to treat peptic ulcer disease. Right? Okay. And then, lastly, by giving proton pump inhibitors. So this we inhibit the production of hydrochloric, the last stage of production of ACL. And we also can give a prostaglandin analog. Example is misoprostol. So misoprostol will inhibit the protein kinase, and this will reduce the production of the acids. Why do you need to treat PUD properly? Because the pain is very severe, right? Furthermore, the complication is very devastating, right? It can cause profuse bleeding, right? If the erosion erodes up to the blood vessel, it will cause profuse bleeding. Okay, and it also can cause perforations if the erosion go through all the layers. Okay, in rare cases, it may cause obstruction. The patient may die due to this reason. I have seen an old patient die due to operation of PUD due to prolonged use of Antacids taken from a Chinese therapist for his knee pain. Right? Now I will discuss the treatment of PUD one by one. We start with H2 receptor antagonists. Example of this drug is cimetidine, famotidine, and ranitidines. Right? This drug will reduce acid secretion by 70%. Okay? H2 receptor antagonist is a selective competitive inhibitor of histamine H2 receptors in the stomach. All right? Or precisely at the parietal cells. Okay, combining this receptor will reduce the activity of protein kinase, which will reduce the secretion of hydrochloric acids. Okay. Clinical use. These drugs are very effective for the treatment and prophylaxis of acute stress ulcer. All right. It's very effective in healing duodenal ulcer and gastritis. We sometimes give intravenous H2 antagonists as PUD prophylaxis for patient in ICU or patient undergoes major surgery. All right. This drug will also important in the treatment of GERD. All right. H2 antagonist is well tolerated. All right. But giving cimetidine may cause gynecomastia and galactorrhea because these drugs have anti-androgen effects. Cimetidine is also an enzyme inhibitor for a drug like ketoconazole, warfarin, and phenytoin. Right. Nowadays, the use of an H2 antagonist was overshadowed by the proton pump inhibitor. Proton pump inhibitors or PPI. All right. Example of these drugs includes omeprazole, osimeprazole, and others. All right. These drugs are very effective in reducing hydrochloric secretions. It was noted it could reach up to more than 90% reductions. Okay. PPI works by irreversibly blocking the hydrogen potassium ATPase enzyme system, or we call it proton pump. Okay, this will suppress hydrogen secretion into the gastric lumens, as this is the final step of acid productions. Okay, PPI usage is more superior than H2 antagonists in suppressing acid production and healing ulcer. Okay. PPI is the preferred drug for GERD treatment, erosive esophagitis, active duodenal ulcer, Zollinger-Ellison syndromes, prevent the risk from prolonged usage of Antacids and ulcer prophylaxis. Okay, PPI normally used as combined therapy with antimicrobial regimens to eradicate H. pylori. Right? Okay, PPI is a prodrug. Oh. PPI is a prodrug that is activated by acids. Okay, it comes as an enteric-coated tablet to protect from premature degradation of gastric acid. All right, it will be removed by alkaline in the duodenums. All right, the absorption of omeprazole occurs in the small intestine and usually completed within 3 to 6 hours. All right, omeprazole have a half-life of 0.5 to 1 hour, but the pharmacological effects of omeprazole last longer as it is covalently bonded to a proton pump on parietal cell to induce effects. Okay, therefore the duration of action is about 18 hours. Right. The absorption will be faster with the presence of sodium bicarbonate. All right. Generally, PPI is well tolerated. All right. It has drug interaction with clopidogrel. So this is antiplatelet. The usage of PPI will suppress the absorption of B12 and calcium carbonates. So this will in long run put the bone at the risk of fracture. Okay. Other adverse effects includes diarrhea, abdominal pains, and headaches. PPI user also at higher risk to get respiratory and enteric infections. Right. Antacids. Previously, this is the main treatment to treat PUD. Example of drugs in this group are aluminum hydroxide, magnesium hydroxide, or the combination of it. Right? The principles are to neutralize the gastric acid by using wheat base. Right? The efficacy will be increased if the stomach is full, as this will delay the emptying time. Right? The antacid will not be absorbed. The adverse effect of aluminum hydroxide are constipations, and the adverse effects of magnesium hydroxide are laxative. At this moment, we still use antacid for symptomatic relief of peptic ulcer disease, heartburn, and GERD. Prostaglandins. The analog of prostaglandin E1 is misoprostol. Okay. The function of prostaglandin E1 is to inhibit acid secretions and increase mucosal protection. It is by secretion of mucus and bicarbonates. So misoprostol needs to be given with multiple doses in a day. Alright. Commonly used as prophylaxis of getting an ulcer in chronic user of Antacids. The adverse effect includes gastrointestinal upsets and diarrhea. Important to note that you will not give misoprostol to pregnant women. It may stimulate uterine contraction and causing the delivery of a premature baby. Mucosal protective agents. It is also known as cytoprotective compounds. One of the agent is sucrose. Right? When sucrose is given to the patient, it will form complex gels with epithelial cells. All right? These complex gels will become a physical barrier that protect the ulcer from pepsins and hydrochloric acids. Those allowing time for the ulcer to heal. Right? Sucrose needs an acidic environment for activations. Therefore, we should not give sucrose together with acid-reducing agents such as PPI, H2 antagonists, or Antacids. Alright. Lastly, the most important part of the treatment of PUD is by using antibiotics. As a matter of fact, Helicobacter pylori contributes to 90 to 100% of duodenal ulcers and 60 to 100% of gastric ulcer patients. How HP causes ulcers? Basically, the H. pylori bacteria weakens the stomach's and duodenal protective mucous coating, thus allowing acid to get through to the sensitive lining beneath. Right? Both the acid and bacteria irritates the lining and cause a sore or ulcer. Therefore, eradicating H. pylori is very, very important if you want to treat the ulcer properly. It will result in rapid healing of active ulcer and cause low recurrent rates. Okay, H. pylori are contagious. The germs may live in your saliva. It will be best if you avoid mouth kissing or drinking from somebody else's mouth or etc. Right? Typically, the bacteria enter the mouth and work their way into the gastrointestinal tract. Nowadays, the treatment of PUD will usually involve multiple drug regimes. Okay, quadruplex regimes. This is the first line options. Okay, it involves PPI plus bismuth subsalicylates plus metronidazole plus tetracyclines. All right. Alternatively, you can give triple regimes. This will involve PPI plus amoxicillin plus clarithromycin. Okay, by giving these regimes, we can get more than 90% eradication rates, and the ulcer will heal faster, and we can expect a low recurrent rates. As part of the training, of one best answer question, please answer this question. A 45 years old man with a duodenal ulcer was treated with a combination of drugs. It tended to heal the mucosa damage and to eradicate Helicobacter pylori. Which of the following antibacterial drugs used commonly to eradicate intestinal H. pylori? A, B, C, D. Choose which one. Thank you. So hope to see you again. All right. Thank you. Thank you.